the lining of the blood vessels. And that's why we're really saying tonight that the lining of the blood vessels is abnormal, that fatty buildup occurs, cholesterol buildup occurs. It's commonly called plaque, and this plaque builds up in the walls of the arteries and tends to cause narrowing and even total blockage. And when a total blockage occurs in a heart, for instance, that's called a myocardial infarction, or commonly a heart attack. And that's a very severe condition, because when the blood stops to part of the cardiac muscle, then that muscle dies and that area is damaged. And if it's not treated properly, then you can have serious long-term damage to the heart muscle, which is a main pumping thing in the heart, and can really cause weakness and even heart failure and death. So we in cardiovascular disease like to prevent this sort of thing before it happens. So again, we stressed modifying risk factors, and again, diabetes is another such risk factor that adds to the other risk factors. And to treat diabetes, one of the best ways is a good diet, weight loss, and exercise, along with medications as needed, and also treatment of the cholesterol with statins, also a little aspirin, sort of a combination approach to treatment of vascular disease. So, Jeff, have you had any other experiences with this? I bet you a lot of people have been asking you about your exercise program and things.
I would say, basically
daily, right?
Yeah, you got to have more go out than what comes in, basically. So you got to eat less and burn off more calories. And my only advice to people, because I know it's a big thing these days as far as diet and trying to lose weight, the advice I could give people is, pick one thing. Pick something very small to cut out of your diet. Don't go for everything at once, like I'm going to cut my diet drastically, I'm going to start exercising all the time, and I'm doing all this starting tomorrow morning. I think that sets you up for a failure. I would tell you the best way, and what worked for me, was you pick the small things. Pick a few things that are, I'm not going to eat stuff with sugar in it or sweets or junk food. I'm going to do whatever else I want, but I'm going to cut that out. Once you do that for a while and see results, then I think you start cutting towards more aggressive things, and then then you put your exercise in on top of that and start to kind of be a little bit more active after that. I've gone from someone who really wouldn't want to go out and even go for a walk and walk much more of a mile, and a few weeks ago I actually ran a half marathon. So it can be done, and I think you just got to take it slow and not try and change your life all at once. Otherwise, I think you set you up for a little bit of failure.
Take little small steps at a time. Probably good advice in a lot of things.
Absolutely.
Mike, have you seen that happen with vascular disease too? I mean, does exercise help treatment of vascular disease, especially the legs?
Well, I would say the vast majority of the patients who I see with claudication, meaning that they have difficulty walking because of blocked or narrowed arteries in their legs, the vast majority of those patients should initially be treated with an exercise program and modification of risk factors. And if they strongly adhere to those things and exercise, almost every one of them, if they're not limb-threatening, will never have a limb-threatening situation and will continue to improve their ability to walk. Now, on the other hand, when someone comes in with a gangrenous toe or a non-healing ulcer, when it is a limb-threatening situation, then that's when you need to get real aggressive and get things opened up fairly quickly.
So really the treatment of peripheral vascular disease is predicated then on symptoms and findings. It's not just so it's there. If it's asymptomatic, there's no damage to the foot or limb with lack of flow, then you can sort of treat it medically. Isn't that right?
Absolutely. There are millions and millions of people in the United States with blocked arteries, and if we thought we had to open up every one of them, we would break the system more than it's already broken.
Good. There's a question for Dr. Bissing I just heard. So, Jeff, you want to take that question, please?
Absolutely, Bill. The question I have, which I'll just read, it said from a patient, said a TEE has been suggested to determine the size of the PFO, which is patent foramen ovale, again, that hole between the top two chambers I have. To do this to help decide the need for closing this. Said I've been putting off, however, due to anxiety about what the TEE procedure will entail, discomfort, etc., and also said they have a hiatal hernia. can you allay some of the anxiety? Thanks in advance. I would first say, to answer that question, I hope tonight's presentation was some help in that. Clearly, as you could see, I mean, the patient was comfortable during the whole procedure, and the key is sedation. And as I told the patient tonight before we started, you know, we give plenty of medicine, and that's so the patient's comfortable, so we can get good images and see what we want to see. So basically what you do is once the procedure starts, the last thing most people remember is actually having the back of their throat sprayed to kind of numb it up. And after that, don't remember much till it's all over. And so that's probably what I could say to allay your anxiety more than anything. The other point I would make about PFO, or patent foraminal valley, this opening up there, you know, depending on the size of it, it also depends whether it gets closed. It's based on if you've ever had any symptoms. Still recommending that patients, if they do have a patent foraminal valley or a hole up there in the top chambers of the heart, they need to have had some type of symptoms, subsequently a prior stroke, mini strokes called TIAs or something, then have the hole that's big enough as well too, and then that's reason to close that thing. But not just because there's a hole there is not necessarily a reason to close it all the time. So
right.
I hope that helps a little bit in allaying some anxiety. Like I said, watching tonight's procedure and seeing how well things went, hopefully that helps that person some.
Yeah, I think a whole clinical picture is what you're saying is important, not just the presence or absence of a PFO, although that's certainly important. You need to look at the whole picture before you decide whether a PFO needs to be closed.
I would absolutely agree with you, Bill. You know, everything's got to be put together, and not only testing, but exam and history in all parts of medicine is how you decide how to treat people. And then you decide benefit versus risk, and also that information is based on studies and things that we do.
I have another question here. I might start answering it, and you can help me with this. But I have a heart murmur, and how often, this is a question, I have a heart murmur, and how often should I have an echo or a TEE? I guess, first of all, we ought to really define or explain what a heart murmur is, because this is a very common problem. A heart murmur is a sound that the doctor hears while listening to the heart. It's a noise, and it's caused by blood flowing through the heart. And a noise can be either due to a very normal finding, which a heart maybe vibrates, a younger person. A lot of younger patients, almost all of them, have some mild heart murmur. That's because you hear the blood move through the heart. Just because it's sort of an analogy I like to give. You turn on the faucet, the pipes rattle, but that doesn't mean the pipes are broken or you have something really wrong. It's just the blood flow or the flow in the pipes making the pipes vibrate. And that can also be the cause. The same thing is true with the heart. And in fact, most heart murmurs, a large majority of them, are very benign and don't mean anything. Now, a certain small amount are important to know about and to do something with, and that's what we were doing tonight. This patient that Jeff did the TE on presented with a heart murmur. Her physician heard it, and he was concerned about, you know, the ramifications of it. So that's when we step up and do the examinations of a echocardiogram, or even more so, if that regular echocardiogram through the chest is abnormal, we do the TE. And that's not done in every patient, as we said, just on selected patients. But how often do you think we should do a heart murmur, Jeff? An echocardiogram in people with heart murmurs?
I would agree with you, and I would say that, you know, just like tonight, I mean, the first step is a transthoracic echo. And, you know, as I said a few minutes ago, you know, this TE is an easy procedure to do from the standpoint of getting it done and, you know, laying anxiety for that gentleman who sent that question. But, you know, it's still an invasive procedure. And if you don't have to have an invasive procedure done, you shouldn't have that procedure done. So I agree. You know, hearing a murmur, you know, murmurs can be about anything. And I think you start with the transthoracic echo. Depending on what that shows, I mean, sometimes valvular anatomy is completely normal, and you don't need any further follow-up at that point. I think if you get the adequate images that you need on transthoracic echo that can be done in your doctor's office, cardiologist's office like ours, then, you know, depending on what that lesion is or how bad that is, I think decides how frequent you need to have a repeat echocardiogram. And again, if it's severe or you can't answer that question, that's the time that you go to transesophageal echocardiogram. But I guess I'd have a hard time just saying, you know, anybody with a murmur ought to have an echo, you know, every year or something like that. I think it needs to be individualized. And I think depending on what the valve or issue is at that time.
I sort of have a follow-up question here. We're running out of time here. Only have a couple minutes left, but briefly, a follow-up question is, how do you decide when a heart murmur is serious enough to need surgery? Now, it's not really the heart murmur we're talking about. Heart murmur, it's a heart valve abnormality, a heart lesion, which is causing the heart murmur. So the heart murmur is not the disease. The valve abnormality or malfunction is the disease. But how do we tell it's serious enough to go to surgery, need to be fixed? Jeff, you want to approach that just in a minute or so, real
Sure.
briefly?
I think, that depends on what valve's involved. And,